So it's a great pleasure of mine to introduce Tracy. Tracy's probably known to most of you, our myeloma nurse consultant. She's one of the few in Australia, in fact, and we're delighted to have her with us at Prince Alfred. And she's going to talk to you about the side effects and the management. Tracy?
I'll give you that, Prof. So. Thanks, Professor Joshua, and I have prepared some slides for this session, but as Professor Joshua said, we'd like to make it interactive and relevant to the questions you may have in this room. So, as you know, this session is being webcast, so if you do ask a question, I will repeat it so that our friends and colleagues online are able to hear what we're talking about. So, the aims of this session are to have a bit of an understanding of the common side effects of myeloma treatment and their associations, but also to learn from each other, because managing side effects often comes down to learning how to manage these amongst yourselves, and not always directed by your nurses and doctors and within the literature. So there is a lot to learn from each other, so do take the opportunity to, if you do have an answer to somebody's question, to put up your hand and we'll talk about that openly as well. Managing side effects can be tricky. It's something that I get asked a lot in my clinical practice, and often after a patient has seen the doctor. And I think often that you save all your sort of salient questions and the important things to within your consult with your specialist, and don't always talk to them about some of the side effects. And sometimes because you might not feel they're the important questions or things that maybe your doctor can help you with, but it is important to be able to talk to your doctor about those. And this is a nice little cartoon here with a donkey sitting in front of his clinician. So if anybody does feel that they're growing ears and sprouting hairs and turning into a donkey, we'll get Professor Joshua to address those questions. I haven't seen it yet. So managing symptoms and side effects, and I will just pause there also, just to let you know that the slides that I have prepared, I have made available in a printout, which I've left outside the room. And for anybody that might be listening in on the webcast, I'd be happy to provide you with an email copy of these slides too, if you just send in a text or an email inquiry to us. I've also put outside the room some other fact sheets and information that support some of the things you may ask and I may talk about. But we know in myeloma, the treatment to manage myeloma includes a range of different tablets and medications that can cause some side effects, as well as symptoms that that may be caused by the underlying disease itself. We often know that these symptoms and side effects can be quite predictable, and we certainly do talk to you about them as you begin a new course of treatment. But you've probably realised that if you open a packet of any medication and you read the patient information fact sheet that comes with any packet of information, and even an aspirin, it's about 5 pages long, isn't it? So it can be quite tricky for us to be able to pick out the more common side effects to talk to you about in a very short appointment we have with you. So we tend to discuss the more common ones, and that's what I'm going to talk to you about. But also, each of you that comes to a diagnosis with myeloma are all wonderfully, beautifully individual human beings. And even though a symptom may be quite common to one particular drug, it doesn't necessarily mean that you as an individual are going to get that symptom or side effect. And also the intensity of any symptom differs widely between individuals because of for a variety of factors, but not so also because of the subjective nature of how you experience something. So when we talk about symptoms and side effects, we need to do that in a very individual way, and people manage them in a very individual way. Also, the symptoms that we may talk to you about relating to any particular medication can depend on whether you are having that treatment for the first time to treat your disease, or whether you might have had myeloma for many years and have inherited some other symptoms along the way. Also can depend on what other health conditions you may bring to your diagnosis. A good example there would be if you were already diabetic and we wanted to give you some high-dose steroids that can cause sugar problems. problems, then obviously somebody that was diabetic may be watching out for those sugar problems more than somebody that doesn't have anything wrong with their sugar levels. We know that it's very important to manage the common side effects of treatment because if we can't manage them effectively, it makes it very difficult for you folks to tolerate the medications that we recommend for you. And if you can't tolerate and take the medications, then in terms of, we talk about outcomes and how well you may do on a particular regimen, that can be affected if you're not able to take the right dose and the right frequency at the right time. So it is very important, and people can do better when their side effects are managed effectively. So where might you go to find the information relating to medicines? Well, clearly your doctor, your hematologist, oncologist, and your GP is the first point of contact and the best place to go for very specific information. What you might have an appointment with your hematologist every 4 weeks or so, so make sure you do keep a little diary. And one of the top tips that I always say to my patients is to keep a patient journal and diary, because recalling things you might want to discuss with your hematologist a month later can be very difficult, and you need to keep lists. So that is certainly a first point of contact. And your GP in the community, if you're unsure whether it's a question for your specialist, such as Professor Joshua or somebody else, then they're always a good place to start. Also, the different nurse specialists, if you're going in and having a blood test in between your visits, that's a good opportunity to ask a question. But also the chemist and the pharmacist. These are members of the healthcare team that certainly have a lot of experience in medicines and how interactions and side effects, and they'd also be a good place to start. A website that I will recommend that you go to is the NPS, which is the National Prescribing Service, and that is a government supported website where you can get accurate, up-to-date information on any of your medicines. And one word of caution about that good old rogue Dr. Google. Do be very, very careful if you just Google a particular side effect, symptom, or medicine without any eye on where the information is coming from, because you could get the wrong information. So just some pointers there for you in terms of where you may go. The common side effects associated with medicines for myeloma are listed here on this slide. Peripheral neuropathy is probably the most common non-blood related side effect, and certainly something that on a daily basis I spend a lot of time talking to patients about, and we'll talk a little bit more about that. Steroids are tablets that come hand in hand with pretty much every medicine that you take or every line of therapy for myeloma, and they certainly can cause problems. I've mentioned the unstable blood sugars, but there's a whole range, and we'll spend a few slides talking about those as well. Blood clots with certain medications we'll talk to very briefly are also an issue in treatment for myeloma. And as a nurse, certainly people love to talk to me about their bowels. My patients or just people on the bus, they seem to know I'm a nurse and talk to me about their bowels. Certainly your bowel habits, your gastric system can get upset at the drop of a hat. Just the thought of having an appointment with your specialist probably enough to turn your tummy over a few times. So GI problems can be a problem, and I can certainly pass on information about that if anybody has any questions. So let's just associate the more common effects with the more common treatments. And here in this slide, I've just listed the common treatment lines of treatment for myeloma: thalidomide-based, lenalidomide-based, which is Revlimid, and bortezomib-based, which is Velcade. And then the common side effects, which are listed down the left-hand side. And as I mentioned, peripheral neuropathy is a common side effect associated with thalidomide and bortezomib-based treatments. We do see it a little bit with lenalidomide, but usually in people that have had lenalidomide after thalidomide. And it talks to the point that sometimes if you inherit a side effect, that can be ongoing. Okay, so you can have compounding effects that live with you, which is another reason why we should manage side effects optimally from the beginning. Blood clots, deep vein thrombosis or pulmonary thrombosis are more commonly associated with the thalidomide and the lenalidomide-based regimens, particularly when we package those together with a cocktail of other drugs. And many of you may find that as you are prescribed certain medication to treat your myeloma, you might have a regimen of containing 3 drugs for your myeloma, but you go out of there with 10 prescriptions. Has anybody found that? I thought I was only have 3 drugs and now I've got lots of different medications to take. And that's because sometimes you need another medication to help prevent the problems of the first one, and things can compound. So we commonly give aspirin with people who are having thalidomide and lenalidomide-based treatments. Lowered counts are being covered in another session, but that is part and parcel of having a blood condition as well as its treatment, and some of those other aspects are linked there. So what I'm going to do now in the next 5 minutes is talk a little bit about peripheral neuropathy, and then we'll take some questions, and then maybe we'll talk about opening it up for questions as well. Does anybody have a particular question about so far? No? Okay, we'll move on and we'll talk about neuropathy. So peripheral neuropathy talks about is a condition which involves damage to the peripheral nerves. And the peripheral nerves, we do commonly think about them in our fingers and toes, don't we? But actually your peripheral nerves are all of the nerves outside of the brain and the spinal cord. Okay, so quite an extensive pathway there. The more common side effect, reasons for peripheral neuropathy, the myeloma protein itself can also contribute to some neuropathy, but and those that might be diabetic. But more commonly, we think about the treatments that are used to manage myeloma. And thalidomide and Velcade are the 2 drug regimens that we use that cause most problems with neuropathy in the context of myeloma. And it certainly is something that most people with myeloma are going to have experience with during the course of their disease. It often starts quite slight and can become more severe over time. People often find it's more troubling at night, and I think that's because the calm of the day comes upon us. In the daytime you're walking about and that can minimize these effects, and at night when things are calm and you're still, you appreciate these symptoms a little bit more. Neuropathy can commonly be pins and needles in the tips of the fingers and toes, but it can also be a change in your ability to sense temperature. So people may say to me, my feet feel cold. I don't have neuropathy, but my feet feel cold and I can't get warm. That actually can be a symptom of neuropathy. So can some pins and needles and some cramping in the lower limbs, and extra sensitivity to touch, or the inability to do something with manual dexterity, such as to do up buttons or pick up a piece of paper from the table. It can also be a lack of coordination. If people get a bit wobbly or feel a bit funny if they stand up too quickly, that also can be a symptom of neuropathy, and you do need to make note of that and discuss that with your doctor at the next appointment. There are people talk to me about neuropathy relating to the thalidomide or the bortezomib lines of treatment, and although for you guys they're quite similar symptoms, there are some differences between the 2 types of neuropathy in terms of the intensity and how common it is, and the particulars between the different signs and symptoms of the neuropathy. But nevertheless, the important key factor for us is for you to let us know if you have any of these signs and symptoms, because the management of neuropathy, which is the most important part, involves understanding the degree to which you have it, and commonly reducing the dose of the treatment that may be causing it. And we can only do that if you're talking to us about the symptoms you may have. The most important management tool that we do have is to reduce the doses of the drugs that might be causing this. And one of the things you may have experienced is that with bortezomib or Velcade, that we have changed the route by which we give this drug in many instances. And instead of giving it intravenously, we commonly give it subcutaneously, a small injection in the tummy. And that is principally because it's supposed to, it's thought to reduce the risk of this nerve damage or neuropathy by up to 1/3, which is good. And we've certainly done that in our practice. There's no magic bullet to manage neuropathy in terms of giving you another pill to fix it. But there are, if it is uncomfortable and painful, there are some tools that we do use, particular medicines that can help manage neuropathic pain. But some of the more common things that we do, we've learned from yourselves, and anecdotal information about various emollients and creams that can be applied to help minimize these symptoms, and they're listed there. Menthol creams, which is, menthol is a component of the sports injury creams, or goanna cream, or things like that, can be very effective topically if you have some of this altered sensation sensations in your hands and feet, and people do use that readily with some effect, and there is actually a paper that has proven that. And we have a patient group that, and I don't advocate using this Saw No More, which is a horse liniment, other to say that its main property is it's about 98% menthol, and that's why it works. But keeping your skin certainly moisturized certainly seems to have an effect, and we're not quite sure what the mechanism of that might be. One of the handouts I have outside of the room for you, and anybody watching online I'd happily pass on to you, are a list of supplements that there is increasingly a body of work looking at whether these may benefit, and the diabetic community certainly recognise that vitamin B12 complex supplemented, particularly if your levels are low, can actually reduce the symptoms of neuropathy. And some of those other supplements are listed there and are on that fact sheet for you to pick up as you go out. There is also a booklet that is available that lists some of the common things you can do to minimise these symptoms, and I've left that copies of that for you outside the room as well. Massage and reflexology are also thought to be effective if you can tolerate the sort of sensation of somebody massaging your skin, and I have patients that use that with very good effect. There are other sort of things that you can do that are listed there, such as wearing flight socks to bed, which just calms down the risk of your bed sheet moving across the lower limbs and causing irritation, which can then wake you up and cause sleeplessness. And some of these strategies are listed in this booklet and are there for you as well. Now, I'm just going to move on to talk a little bit about some steroid effects. So would anybody in the room like to ask a question about peripheral neuropathy or share their experience? Yes, the gentleman at the back.
I just stopped taking Revlimid. The second one, I got a rash, an itch. I started getting fingers,
Yes.
cramps, and so forth. This goes from 15 to 5. And the way I went in, after 4 days, I rang her up and said, tell her the rash is back.
Yes. Okay. So
She ran back and said, stop.
Yes. So I'm just going to repeat that question for people watching online. So the gentleman asked a question associated, and I might ask Professor Joshua to come and address this question. Lenalidomide or Revlimid, which is a tablet you take, and you were taking a 15 milligrams, and you experienced a rash and some cramping, and you were advised to stop taking it. So could you just talk maybe a minute about the association with lenalidomide and rashes?
So rash is a very common side effect of Revlimid or lenalidomide. It is managed by reducing the dose as your physician has done. Sometimes you have to use a small amount of steroid, which just helps with the rash as well, and topical things for the rash. But it is a very common side effect of Revlimid, and we don't know why some people get it, but the incidence I think is quite high. It's almost 20%, so it's quite high.
May I continue?
Yes.
Subsequent, after the second dose, the first dose was okay, the first thing was okay, the second one was dreadful, and the third one has been stopped. That is up to 15 milligrams. But subsequent to the second one, I was in hospital for 2 weeks with golden staph, which may have come from the rash because I lost a lot of skin and dry flakes and so forth. But something you said before, that not only in the feet, but I get a sort of sensation on the hips and inside the knees and so forth. Is that what we're talking about?
So the question is really around altered sensations on the skin. Sensations topically to the skin, but in different areas of the body, such as the hip and the back. And have you had a shingles outbreak or anything like that before?
No, I was treated for shingles for about 3 weeks before I was diagnosed with myeloma.
Yeah. So I suppose, and do you have any myeloma bone disease in that area, the hip or the area that you have some altered sensations on the skin?
Not down there. I've got a collapsed vertebrae, which is my main problem at the moment.
Yeah, yeah.
But the sensation is down in the lower back, down in the buttocks, and down the hips and so forth.
Yeah.
It's not wonderful, and I hit it with moisturising as much as possible.
Yeah. So I suppose, do you want to answer that?
So the important thing is that abnormal sensation with thalidomide and is usually in the hands and the feet. Abnormal sensation that occurs elsewhere, it's important to make sure that there's no local pressure on the nerve that might be supplying that area. So if you've had trouble in your back, there may be some local pressure on the nerve exiting from the spinal cord, which is causing some of that sensation. So there are other causes, and we always have to be aware that there are other causes. If you've had shingles, the area that you had the shingles, even though it may have been treated and cured, always remains sensitive, and you may well find abnormal sensations over an area which you previously had shingles.
Yes, gentleman at the back, and I'll repeat your question.
I had a Velcade treatment this morning, and I'm a chronic tinnitus sufferer.
Yes.
Now, when I woke up this morning, he's down to about a 2, and on previous experience, when I go to bed at night, he'll be about a 10. And then it'll take 2 or 3 days to calm down.
Yeah.
That's a natural reaction.
So the question is about tinnitus or ringing in the ears that might be associated to Velcade or bortezomib. Do you want to comment on that? I've certainly known it happen. Yeah.
I think it does happen. I'm not exactly sure why it happens, but I presume it's a nerve issue. I don't think it's very common. I mean, tinnitus or ringing in the ears doesn't commonly happen with Velcade, but as Tracy said, we've certainly seen people who get it. It may be that you have some predisposition in that nerve for whatever reason that it's allowed it to happen there. But if it's temporarily related to the Velcade and improves when the Velcade stops, it's hard to say it's not due to the Velcade.
Yes, question, Harry.
I heard that silk sheets are often helpful in the bed as well.
Yes, Harry. So the bed clothing that you have, because neuropathy really can be the symptoms of it or the sensations can be worse at night, and then that affects your ability to have a good night's sleep. Patients have told us that low resistant bedding, such as silk sheets, can help because they reduce the potential irritation to the skin as you move about in bed. And the caution there, of course, is that you don't slip around too much and fall straight out of bed and break a hip or something. But yeah, I have heard that, and people who have said that helps very much. So these sort of anecdotal tips and ways that people find to reduce these symptoms are very important. It can also help if you are finding it, if you have aches and pains to the bones, lower back and things, because as you move about in bed, and that causes more pain, and then that causes sleeplessness. So a strategy for neuropathy, but also if you have a lot of bone pain, it can be very effective as well. Any other questions relating to neuropathy? I'm very aware of the time. We might have to move. Yes, the lady at the back, yes.
I could have been neuropathy, affects the balance and everything. I understood that I was going to get. Every night, when I'm just ready to go to sleep or fell asleep, I woke up with a burning feet, and I could not stand 1 second. I have to move it, or I have to jump and go into the bathroom on a tile. Doesn't matter how cold it is.
Yes.
Is that
Yes, so this lady is describing burning sensations in her feet, particularly when she goes to bed at night.
But my feet are always cold.
Yes.
With neuropathy, except when I'm just falling asleep, that's when I hit, and it's burning. Is that neuropathy or is it something else?
No, I think that is exactly neuropathy. Yes, it is
So
the.
I've got a burning and a cold as well.
Yes, yes. And do you find that you do anything that helps with that? Do you wear socks or tight-fitting flight socks or anything like that? Or some massage before you go to bed? Or even people describe, I had on the list there actually, and there's not a lot of hard evidence to say that it's associated or helps, but the circulation boosters or the foot massage or those various things you can get from a high street chemist that give your feet a little massage or in warm water and irritate the water. People do describe to me that they do that routinely before they go to bed at night, and then they put on flight socks or firm fitting socks, and it tends to calm down those sensations as well.
I tried salt warm water and it does help.
Salted warm water to soak your feet before you go to bed. Yes, I've heard things like that can be very effective. The gentleman at the back had a question. Yeah.
I had stem cell transplant when I was followed by 1 year treatment with thalidomide. And gradually I developed neuropathy. And gradually my walking has slowed down. Earlier I used to walk in front of my wife, now my wife walks in front of me. And I can't climb steps unless there are railings to hold on.
Yes. So
Anyway, it can be reversed.
So this gentleman is making mention that he had thalidomide for a year after a transplant, and he has found that his speed or pace of his walking, but also perhaps his gait and his as he walks, and he's a little unsure-footed as he walks. And is there anything that can help with that?
Well, it's time actually. Almost 2/3 of patients with thalidomide neuropathy improve, but that improvement often takes 6 to 9 months. So it is just time. There's no magic bullet that will reverse peripheral thalidomide neuropathy, but it is a bit of time. And there's nothing wrong with walking behind your wife. Happens all the time.
Yes, and actually walking in itself and keeping fit and active can help minimise or help with a lot of side effects. So people do describe that taking some regular exercise and walking in front or behind your loved ones can be very helpful for reducing the symptoms of neuropathy, but also for managing fatigue and making sure you sleep well and increasing your appetite and all these things. So we're not talking today particularly about the importance of exercise and fitness, but it can help across all domains, and it certainly should be something that we promote and advocate. Yep. Another question from the back. Yeah.
You said 8 to 9 months neuropathy improved, and my second transplant was like 7 years ago, and I have not seen improvement in my neuropathy. It's not good.
I said in the majority of patients, 2/3. That's unfortunately, some people do have what appears to be relatively permanent damage, but in the majority, well, 2/3 roughly, the neuropathy will improve, but it takes time. Certainly the Velcade neuropathy will often improve with time. Thalidomide neuropathy seems to be a little bit different, and it often takes a long time or doesn't improve in some patients at all, which is a pity. And that's why we're so pleased to have ways of reducing the Velcade neuropathy with subcutaneous injections. And one of the advantages of some of these new drugs is they seem to have very little neuropathy associated with them, and we're keen to pursue those. Yeah, that's good.
Yeah.
So we have to move.
Yes, we're going to have one more question, and then I think we have to move. We are moving, not necessarily you, to a different subject. So the lady at the back, yes.
I'm sorry?
Do the peripheral nerves regenerate if they have been damaged? Yeah, so the ability for nerves to repair themselves, can they repair themselves? Yeah.
Well, nerves can, but the exact mechanism of why the damage occurs and why it improves is not all that clear, but we do see some improvement. But unfortunately, as I said to you, some people we don't get that improvement that we expect, and it can be quite disabling. But not that much is known about it. But bortezomib in particular, or Velcade, does appear to be toxic more to the nerves, to the nerve roots, but it's a more reversible toxicity than that of thalidomide.